So as we address treatment, let's talk first about who should get treatment. That's not entirely clear, but the basic guidelines for treatment are patients who have a doubling time of their lymphocytes in less than 6 months. Now we make exceptions to that sometimes if someone barely doubles. People who have symptoms, those symptoms being their liver or their spleen or the lymph nodes are big enough that they're causing pain or discomfort, or their spleen is causing them to have difficulty eating. People who have stage 3 or 4 disease, the people with the anemia and thrombocytopenia need therapy, and people who are having symptoms related to their disease, such as we think about with lymphomas, such as night sweats, fevers, and loss of weight. So all of those are potential indications, and your doctor and you will work together to decide if and when you need treatment. As we mentioned earlier, many people with low stage disease may not need treatment now, and many may not ever need treatment, but most don't need treatment right now. So if you take into account those indications for treatment, your doctor will work with you. They'll be following labs frequently every few months early on, but usually every 3 to 6 months after that. And when they see some indication for treatment or you develop new symptoms and let them know, then you'll address when to move forward. When we look at treatment itself, it's very varied, but in general now it involves outpatient chemotherapy. Very seldom do people need to be hospitalized for their treatment for CLL. It can be drugs given over a period of anywhere from 2 to 5 days, every 3 to 4 weeks, and it will be individualized and adjusted. It frequently includes an antibody treatment, such as a drug called rituximab, which attacks, I talked to you about in the diagnosis, some of the markers on the surface of your cells. Well, these are actually antibodies that have been developed to attack those cells' surface markers. And so it actually gets directed at your CLL cells that have those characteristics. And it's relatively gentle on your normal cells, so it doesn't do too much in the way of toxicity. You frequently combine that with other drugs. There's a group of drugs called the nucleoside analogs, the most common of which is fludarabine that frequently is involved in the treatment. And then sometimes we include other drugs like cyclophosphamide, which is an alkylator, and many patients have one of the steroids, either prednisone or dexamethasone, as part of their treatment. And your doctor will work with you and based on your functional status yourself, the aggressiveness of your disease, the stage of your disease, and help you individualize your treatment. What you can take home from this is almost all of these treatments will have some effect on your normal blood cells, so you'll need to be monitored closely to make sure you don't become more anemic and need transfusions, you don't have low platelets and need transfusions of those, and they will be watching very closely for any evidence of infection. The major complication of treatment of any type of leukemia is infection, and certainly that's no different with CLL, so they may have you on some medications to try to prevent infection or have a very low threshold for starting you on antibiotics if and when you develop any early signs of infection. Your treatment will frequently last a number of cycles. More commonly, people think about 6 cycles of treatment, so if you're getting it every 3 or 4 weeks, you can multiply out, it will take you 4 to 6 months of therapy. But that determination of when to stop treatment is also based on how well you respond and the status of your disease.